My name is Robin De Alicante. I'm a field manager with the Citizen Review Board, and I hope everyone here is here for the fetal alcohol syndrome. So I'll just go ahead and without any further ado introduce Diane Malbin. She's kind enough to come present for us. And I think, Diane, you want questions held until the end? So if we could do that, that'd be great. But Diane has a lot of information to provide in a short amount of time, so hold your questions, and if we do have time, we'll be able to answer some questions for you. Thank you, Diane.
Hi, and thanks to Robin again for inviting me to this wonderful occasion. I think CRBs are in a very wonderful and vital position to begin to kind of influence outcomes for children. And my hope is that factoring in a missing key variable may support you in your work and ultimately support the families that you're working with. So I know I have just about a half an hour, and I don't pretend to introduce all of the information, but I just want to kind of encourage you to think about whether or not the topic for today has relevance for the work that you do. Now, I usually start trainings by asking how many people in the room woke up this morning and thought about your brains. Anybody in this room think about your brain function this morning? That kind of chuckle that ran through the room usually says, no, I did not. Most of us have the luxury of going through the day completely oblivious to the amazing things our brains are doing for us on a daily basis. We transition from sleep to wake. We can make the connection between that obnoxious sound and then recognize it as our alarm clock, and then perform our first calculation of the day, which is to count the number of times we can hit snooze so that we won't be late, right? And then we multitask, we communicate quickly, sometimes we're also helping other people get out the door, we're driving cars, we're processing quickly, we're abstracting, we're anticipating, we're doing all kinds of cognitive tasks. And the reason I go on about that and take our precious few minutes is this. If I'm unaware of all the cognitive tasks my brain is providing for me, how do I have a basis for comparison with how other people's brains may work differently? And the problem is this, that the majority of the children in foster care, 80% according to the Oregon cohort study, come from families where there are addictions. Not just alcohol, other drugs as well. And the central piece about that, the importance of that, is to understand that if there's use of alcohol and other drugs during pregnancy, then what you're dealing with is a child who has a degree of brain damage. Their brains work differently. So all those cognitive tasks that we're unaware of, research has found that those are just the same areas that these guys have difficulty with. They have difficulty transitioning from sleep to wake. They have difficulty making decisions. They have difficulty forming associations between weather and clothing. They process very slowly. They get every third word of normally paced speech. They talk the talk, they don't walk the walk. They make sure that you know that if you ask them what's the rule, they'll tell you the rule. What's going to happen if you break the rule? They'll tell you. They make sure that you know if somebody else breaks the rule, but then when they break the rule, they can't figure out why they're in trouble. And so we see over time, and this is kind of a classic story. I'll tell you the story about Fred. Fred was in foster care. The state of Oregon funded our small nonprofit to do an interventive study based on a neurobehavioral model, and it was wonderful, and all the children in the study were in foster care. Now at that point, 10 years ago, there were no other studies that existed that were interventive studies. And the child who's our poster child, who's referred to this study, his name is Fred. Now when Fred came to our study, he was referred to us today that his very skilled foster mother called up the caseworker and said, if you don't pick this kid up today, I'm dropping him off on your doorstep. Have you ever heard stories like that? A little bit of frustration, right? The caseworker had just heard about this new project, and he said, would you try one more thing? And the parent said, okay. Long story short, basically, the neurobehavioral model and the logic model that you have in front of you says, if then. If alcohol destroys cells in the brain and affects the design of the brain, that manifests in behavioral symptoms. So we have a neurobehavioral problem. And unfortunately, in most cases, 90% of the cases, if not more, it's completely invisible. So we're talking about an invisible disability with behavioral symptoms. So over the years, what happened to Fred was that he was moved from the front of the class to the back of the class to the hallway. He was given more diagnoses. He was failure to thrive. He was speech and language delayed. He had reactive attachment disorder. He was oppositional defiant disorder. And he had all these different diagnoses. And he was also in very good care. He had all kinds of really good programs, right? And none of them worked very well for him. He couldn't figure it out. So the day that Fred was referred to us was he was in a very skilled day treatment center where the staff was getting ready to refer him on to residential treatment. Why? Because he had temper tantrums every day. And the staff couldn't figure it out, and nothing was working. So they were going to refer him on to residential treatment at 7.5. What we also learned about Fred was that he was seen as socially inappropriate and, of course, oppositional. He failed to follow through when people would tell him to do things, right? So we came along and we asked a different set of questions that started with what we know from research about brain dysfunction associated with prenatal exposure to alcohol and other drugs. And what those questions illustrated or illuminated in Fred's case was this. Fred was actually a very competent 3-year-old in a 7-year-old body because he has this thing called dysmaturity. Dysmaturity is not because of multiple placements. Dysmaturity is not because of chaos in the home. Dysmaturity is where you take a developmental timeline and stretch it. It takes these guys longer to master the developmental stages and the earlier developmental levels. We also found out that Fred had very slow processing, and literally, he could only hear every third word of what was said to him. And so people thought that he was ignoring them, that he wasn't paying attention. And of course, he got all those DSM diagnoses and all those medications. We also found out that Fred had very slow cognitive processing, and he had 2 other characteristics. He was very rigid and very perseverative. You ever heard stories about kids who have difficulty letting go? They kind of get stuck in an argument, right? Okay, factor in brain function. Just ask that what-if question, okay? Well, we found out what the problem was, the problem that couldn't be solved in the day treatment program. It turns out that Fred's temper tantrums that were going to get him referred to residential treatment didn't happen randomly during the day. It happened every day at the end of math class. And then we found out that he had this really, truly wonderful teacher. And what the teacher would do at the beginning of the class, he'd give everybody in the class the page of math problems with the instructions to finish the problems in the allotted time, right? Well, the other kids would be done with the math problems, and Fred would be down to problem number 5. He also had this rigidity and perseveration, as I just mentioned. And the teacher would come along and say, "It's okay, Fred, put it away. You don't have to finish now, you can finish it later." And Fred, being rigid and not being able to simply stop, wouldn't just say no, he would say hell no, and he'd fight. Now here's the kicker. Because he'd been given the diagnosis of oppositional defiant disorder, what do you think was written into his treatment plan? Fred will comply with adult directives, right? Okay, and otherwise it's great practice. But what I didn't realize was the reason Fred couldn't comply was because he hadn't finished. And he had this like biological imperative to finish what he was doing. As soon as they figured out what the problem was, the solution was obvious. The next day, the teacher went into class, gave everybody the paper of arithmetic except for Fred, and he got 5 problems. At the end of the allotted time, he'd finished, end of problems. No more temper tantrums. Okay, so it's not always that simple, but really, what is simple is almost too simplistic. The behaviors make sense, but they make a different kind of sense. Fred's behavior made a different kind of sense, and people stopped being so frustrated with him. They adjusted their expectations. They were able to factor in his brain function and brain dysfunction, and from there, we were able to provide appropriate accommodations. I think Fred's study is important, or his story is important, because how many kids, as I'm telling you the story of Fred, can you think of where you have a similar kind of a phenomenon happening? We try harder and harder using good techniques, and nothing works. And what usually happens then is we call for another assessment, and we get another medication, and that doesn't work. And I'm just encouraging you to consider a what-if question. If you leave here at the end of a half hour, and you're simply saying, wow, Well, maybe brain function does have something to do with behaviors, and maybe the 30 years of research and over 25,000 research articles that have been published have some validity. Then I've done my job. And if you leave here and you go to the next meeting and you say, wait a second, what about brain function? Then that opens the door to exploration. And I'm here to tell you something that's really exciting. As of April 30th and April 29th, respectively, there are 2 earth-shaking changes that have happened in the field. The Scientific American published an article that says the DSM has failed because it has not recognized, has not recognized the neurobiology that we have, the research that we have, and the director of the NIMH has distanced himself from the DSM, saying we have missed the mark. And they're going to be calling for much more research looking at brain function and redefining mental conditions on the basis of what we know and what we will continue to learn about the brain. So we're on the edge of a big change. I mean, we've only been saying this for the last 25 years, but it's really cool. It's beginning to happen big time. Okay, let me just kind of run through this fairly quickly. Can you think of any behavior in your life that doesn't require brain function? When you think about it, is there any single behavior in your life that does not require brain function? Every single behavior. And yet, because of our paradigm, we fail to recognize the brain as the source of all behaviors. What you have in front of you is material that will help to reorganize the behaviors in a manner that's more consistent with research. The Neurobehavioral Foundation is a research-informed, theoretically grounded approach to understanding behaviors differently. It does not excuse, it does not condone, it does not enable anyone. It does help us to understand differently. Let's see. I mentioned this very briefly, and I'll say it one more time very quickly. The if-then, and this is how the logic model works. If we know from research that alcohol and other drugs and other events can change the design of the brain, the question is, are those physical changes? Is the brain a physical organ? Is the brain a physical organ? I mean, just because we're oblivious to it doesn't make it any less physical. No, it's a physical organ. Physical changes in the brain, right? Now the problem is that if there are physical changes in the brain, there may be 0 indicators, no observable external markers that give us a clue. The only symptom is what? Behaviors, and that's the problem. That's the problem. Okay? If anybody in this room is familiar with the diagnostic criteria for fetal alcohol syndrome, that's the medical diagnosis for the extreme end of the physical characteristics associated with prenatal alcohol exposure, you have to have 3 facial features that's required for the diagnosis. Small eyes, flat filter, and thin upper lip. That's the triad. Now, here's the kicker. The only time during pregnancy that alcohol can cause those 3 characteristics, is between days 18 and 21 of gestation. That's it. That's it. So alcohol exposure during that very small window of time is the only time that alcohol can cause those features that are required for the medical diagnosis. The problem is that alcohol exposure prior to those 3 days or after may affect the developing brain in very different ways. And you will have none of those physical features that are required for the diagnosis. In fact, the majority of children are born without any physical indicators, and they are at greater risk. Why? Because they talk. They look great. They're in our face. They're in our space. As mom once said, one of the moms once said, if my daughter had a missing leg, people would have compassion for her. They would understand what her needs were. But because her invisible disability is invisible and it's in her behaviors, they just get angry and just want to stop the behaviors. Does that sound reasonable? Okay, so the logic model says if then, if it's true, and we've got the research, that these ingredients can affect the design of the brain, and the only symptoms are behavioral, then it follows that we're talking about an invisible physical disability with behavioral symptoms. And that's both the gift and the problem. But here's what it dictates. And in your handouts, page 2, there's a very brief 2-page overview of what differentiates standard learning theory behavioral approach from a neurobehavioral approach. It's like night and day. If it's a physical disability, then we shift from trying to change the behaviors in the person and watching them get worse to achieving changes by recognizing etiology. As Sterling Clarence said, and he's my mentor, and he's phenomenal, he said, you know, what we end up doing inadvertently with people before we identify this condition is like beating the blind child for refusing to read the blackboard. They look like they could, and they've got 2 eyes, just try a little harder. If you were motivated, you could do it. If you didn't have such lousy parents, you could do it. We assign meaning to the behaviors that has nothing to do with etiology. Nobody would beat a blind child for refusing to read the blackboard, but what do we need? We just need that piece of information that maybe the child can't see. When we factor that question into the equation, the shift is profound. The shift is from seeing the person as somebody who won't do something to somebody who maybe can't do something. Same person, same behavior, 2 very different lenses. And the emotional quality of the relationship changes dramatically. When I believe a person is doing something intentionally, that they won't do something because they could if they tried, then I get angry. But if I can then see that behavior differently and say, oh my God, maybe it's not that they won't, they just can't do it, I feel compassion. The emotional quality based on those 2 very different perceptions is what defines success as I see it, because it's all about relationship. And it works. We've tested it, and it works. What you have here is, I want you to know that as we're talking, yes, this is about fetal alcohol, but there are like 50,000 teratogens that exist, and a teratogen is something that negatively affects pregnancy outcome. And of the ones studied so far, the 5,000 have been studied, the leading one is still alcohol. Did you know that fetal alcohol is not a problem that's limited to Aboriginal communities, Native American communities, or undereducated communities? And I just read online just yesterday, we're talking about the higher the education, the higher the income, the greater the likelihood of binge drinking during pregnancy. Right? Okay. Anyway, but there's a saying in the field too, that if your income's over $50,000 a year, your child has Asperger's, and if it's under $50,000 a year, it's fetal alcohol. There's a bias and a prejudice. It's true. It's out there. Okay. Anyway, this is basically saying there are a number of different things that can affect brain function. Any one or a combination of these may contribute to the same neurobehavioral symptoms. So a person may have fallen off a bike and they have memory problems. They might have been prenatally exposed to alcohol and they have memory problems. I'm not trying to get down to this level of quibbling over what caused what at exactly what minute, because that'll drive you nuts. I promise that. This is a photograph of a boy, obviously, state the obvious, and he has full FAS, fairly severe. And among the characteristics of people with fetal alcohol that's rarely considered is this thing called sensory integration. The vast majority of people who came through our diagnostic clinic when we were up and running a number of years ago was that they had sensory issues. So they're either undersensitive or oversensitive, but you often see the behavioral symptoms of their sensory response to the environment. That makes no sense until you begin to factor that in. These 2 boys are biological siblings. They were adopted by a family in Illinois. They're now in their 30s. This oldest boy is actually the older sibling. He's 14 months older than his younger brother. He was diagnosed with full FAS at about this age. His younger brother wasn't identified as being on the spectrum until he was hospitalized with suicidal depression when he was 15. And his mother was absolutely blown away. And she said, all these years we've been providing accommodations for his brother because he had a diagnosis of fetal alcohol, but we treated him like a behavior problem. How often do you think that happens? And it's nobody's fault. I'll simply ask questions within the framework I have, and all I'm asking you to consider in that what-if question is what if we can expand our framework to consider brain function, that's all. So we don't have to have those kinds of sad stories anymore. And please don't, please don't start looking for people with fetal alcohol as being kind of short and kind of these curious-looking faces. Sydney has full FAS. She's now in her 30s. This was taken when she was 18. Full FAS. And she's absolutely gorgeous. She's now married. She's living in Italy with her husband. And she doesn't manage her checkbook. Big deal. Last time I looked, the world was still revolving. I believe that as we begin to think about not just what we're doing today, but what are the goals that we have for our children that we're working with, independence seems to be a very dearly held value in the macro culture in this country. I suggest considering the language of interdependence, because to me that means there's a healthy community that's informed and can be much more effective. When we talk about brains and behaviors and behavioral differences, I think this is one of the most useful images that we can talk about, because, you know, just a second ago we were talking about Sydney and facial features, but again, if we're talking about an invisible condition, let's take a look at etiology. This is a drawing that came from alcoholism clinical and experimental research. And it was a drawing from a photograph that was of two cells from two different rats, cells in the brain from two different rats. This one is neurotypical. And again, it's the presence of this physical structure that allows us to do all these amazing cognitive tasks as we go through the day without being aware of it. We have the nucleus where information is received, and then the electrical current travels down the axon very quickly, because there's a protective sheath. It's like that plastic coating they put on the outside of electric wires. And then there's a tremendous array, a rich array of neurons or dendrites that connect to the different cells in the brain. That allows us to shift gears, to be able to adapt, to be able to process, to store information, to form concepts, to do executive functioning, all these kinds of things. And by comparison, this is the cell from the brain of a rat whose mother was given megadoses of alcohol during pregnancy. Alcohol acts like a solvent, and there's demyelination. So if you had an electric wire without that protective plastic coating, what do you think would happen to the electric current as it travels down that wire? It short circuits, you have greater resistance, and that parallel plays out here. The way this can show up is around things like central auditory processing delay. At the beginning, I kind of mentioned that some of these guys can only hear every third word of normally paced speech, right? There's a reason for it. But here's the problem. A lot of these guys can pass good hearing screening tests because we put the earphones on, right, and we give them a tone, and they can raise a finger when they hear the tone. Is that true? Is that what we do? Okay. So they pass those screening tests, but here's the problem. When you think about it, what is a single word? One word is a collection of sounds. And in order for us to comprehend language, the brain has to be processing at lightning speed, instantaneously. Now the question is, oh, and by the way, by definition, since they're collections of sounds, words are also abstract. Now what if it takes 100,000 cells to go from hearing a collection of sounds, which is a word, to finding the meaning in the brain? And what if you have just a bazillionth of a second delay at every single juncture, at every single cell? What that translates into is that by the time that first word finds meaning in the brain, the next 2 or 3 words have gone by. That's central auditory processing delay. It would be like if you're sitting in this room, if you could only hear every word of given, right? If you were sitting in this room and you could only hear every third word of what I'm saying in a very short time, you're going to give me evidence it's not working for you. We see agitation, we see anxiety, we see kids looking distracted, and that's why they start getting the diagnosis of ADD, right? But they often don't get it. They just don't get it because they process more slowly and they listen more slowly. I'm giving you some examples because these are some of the kinds of behaviors that we see that without this information we can interpret as they're not caring. They're not trying. They're ignoring me, right? Okay. This is the universal kind of scary photograph. Oops, I did something wrong. Oh, there. Of the comparison between a theoretically neurotypical brain and one with fetal alcohol. I don't show it for scare value, But to reinforce, we're talking about a physical disability. You don't have to be a neuroscientist to see that there's a dramatic difference between those two brains. And I'm not going to say more than that, except for you to know this could also be the brain of somebody with fetal alcohol. And this is the most extreme example of fetal alcohol. So when we're talking about that, they've done studies in Germany. They're trying to find a brain that has been that seriously or severely affected, and they can't find one over 30 years. Okay, it's the most extreme example, just so you know. Okay. In your handouts, I think we're up to page 2. 3, it's actually on page 5. I'm not going to spend much time going through this because we don't have much time. But this is the Facets Neurobehavioral Screening Tool, and believe me, I looked through the literature, and I know other people who've looked through the literature to find a good screening tool that was informed by the literature. There are lots and lots of screening tools out there, but they fail to recognize etiology. They fail to organize the symptoms according to what we know from the research. And in that document, what you're looking at now, I'm going to give you a couple of definitions. Primary behaviors, and this is about retraining our brains and about understanding behaviors as they're collected differently than in DSM diagnoses. Primary behaviors reflect underlying brain structure and function, and they include strengths. I hope that each of you advocates, if there's any assessment that's done, that include a neuropsych as often as possible, a good OT that looks at sensory systems, and also that each person who's doing an assessment identifies a person's strengths, their learning abilities, because without that, we're left with deficits, and we tend to focus on deficits rather than on strengths. This is the list of the categories that I believe are best informed by literature. This was out in field testing for about 5 years, and we got really good feedback from parents and professionals, and we have adapted it accordingly. So developmental level of functioning, and please remember that it's not uncommon for a person to be functioning in some areas, not all, at about half their chronological age. That's hugely important. This is not incidental. It's central for understanding the person. Sensory systems, nutrition, I could go on. And this is why I teach a year-long course, basically. When we talk about uneven development, I think this is important to be aware of. We all have uneven development. For people with fetal alcohol, it's more extreme, and you see that variability that might be much more damaging. So if we have a person who, let's say, chronologically is 18 years old, then socially and emotionally there may be 9. I want you to consider the question, how do we group children? Do we group them by developmental level of functioning, or do we group them by age? I want you to consider what's the net effect going to be on a child who starts in kindergarten, who's developmentally 2.5 years old, and they're getting in trouble because they're not playing nicely with other kids, they're not sharing and taking turns, because they're still doing parallel play. It's developmentally appropriate for them, but they're seen as being the problem. They're 6 going on 3. They're 8 going on 4. They're 12 going on 6. They're 18 going on 9. What do you think it's going to look like socially for these guys? How do you think they're going to get treated? Please be aware of that. Because if we're talking about bullying and preventing bullying, I think this may be a very useful variable to consider. Strengths and interests, there are many more than this, but I encourage you to consider that. Learning strengths is really important because if a person is not an auditory learner, if they have slow auditory processing, but they're more visual, then what we can do is, instead of repeating and repeating and repeating, what we can do is recognize what their strength is and build on that. Okay, so be aware of what their strengths are. Secondary behaviors are the ones we know and love so well, and you probably hear them at every single CRB meeting. They're defensive behaviors that reflect pain and a poor fit between the person and their world. They are normal human reactions to pain. Okay? But they're seen as being the problem, unfortunately. By definition, these are preventable. We predicted, our hypothesis said in the Oregon study, that we would achieve a statistically significant decrease in the challenging secondary behaviors in the children, and we did. It works differently. This is a drawing that was done by a mom up in Canada. And we were talking about, the different kinds of secondary behaviors, the anger, the aggression, those kinds of things. And she said, oh, I get it. She said, this is our son. This is me. This is his teacher. And that's his dad. And all these years we've been yelling at him because we've gotten more and more scared. And she was feeling terrible. She understood him differently. Secondary behaviors, easily tired. They get really fatigued. These are like 8 and 10-year-olds who come home and take a nap. Or they get really hyperactive because they're so exhausted. Anxiety is a very big issue. Lonely, isolated, again, if there's that dismaturity, they never really fit in, you're going to see a lot of that. The problem is when we see these behaviors, these are seen as budding mental health problems, and we medicate them. Again, I'm not anti-meds. I'm very concerned about how and when meds are used for what. If a person is displaying anxiety, do we simply medicate, or do we figure out what's anxiogenic? What's causing the anxiety? In my experience, clinically over 25 years, and professionally, right, in working with different families and systems, figuring out what's causing it and eliminating the root cause is much more effective. And it has been linked with being able to reduce the number of meds and their duration. When we see the behaviors as being the problem, we typically use what kinds of strategies? What do we do to try and change behaviors? Time out? Suspension? What do we do? Whether at home or at school or in the community. Therapy? Jail? And again, the first question is, what are we trying to change? Is it a primary behavior or a secondary behavior? But the techniques that we use not only fail to kind of get to the core, but they, in order for those to be effective, let's say, for example, time out, I think it's useful to ask the question, what does the brain have to be able to do in order for the strategy of time out to be effective? Or just even talking to somebody. Let's pick on talking to somebody. If I'm talking to somebody, I'm using my words, I'm using my logic, I'm making sense, right? In order for that person to benefit from being talked to and then lectured at and yelled at, eventually, what does their brain have to do? It has to process language quickly. It has to be able to form associations. It has to be able to store in memory. It has to be able to form concepts. In order to stay out of trouble tomorrow, it has to be able to abstract and predict, right? Those are just a few of the cognitive requirements for our learning theory behavioral interventions to be effective. Nothing wrong with the technique. But if it's true that people with fetal alcohol have difficulty with just those same cognitive tasks, how effective do you think the technique's going to be? Did it again. When I hear people say, and believe me, I hear it all the time, nothing works. When you step back and you ask the question, now let's look at all these different techniques, the talking, the timeout, the star charts, the love and logic, the 3P, and all those kinds of things. When you're looking at all of those, what does the brain have to be able to do? And what you'll find, in my experience anyway, is about 99.9% of those techniques are all based on the principles of learning theory and unarticulated assumptions about what brains are able to do. And if the brains simply can't perform those cognitive functions, even just one or two of them, yeah, I think it helps to explain why it is that our good techniques may not be effective. It's not about blaming parents, not about implicating professionals or clinicians. There just may be a different question to consider. And this is a big issue. Learning theory is the paradigm that's the basis for behavioral interventions. And behavioral interventions are still used pretty much universally, aren't they? Okay, you got it. All I'm asking you to consider is whether or not brain function has been considered in a meaningful way. What do you think? If it's a poor fit, again, there's no blame, there's no fault in here. You know, I'm using my words, I'm using my good words. And if it's not working, it's nobody's fault, but it's a question of fit. If I'm using my words, but the person, if the person is a visual learner, but I'm talking to them, it's a lousy fit. If the person processes more slowly, but I'm talking really fast, which is my standard MO, it's a really bad fit, right? My kids have had to teach me that. Mom. Okay, you see how that works? Where there's a poor fit, you're going to have secondary behaviors. That's how simple that is. And when there are problem behaviors over time, that's when we see the bigger problems. And we see them in the parents of the children who are in foster care. In my vision of the world, what we're going to start doing is we're going to do a neurobehavioral screen both for the parents as well as the kids. Every single child who comes in care, we're going to scan for brain function so that we can stop the revolving door, so we can really contribute to creating the conditions for health that I think are really important for community. This is not rocket science. Accommodations are almost too simple. It's like we have this mystique. If we're talking about brain function, then whatever we come up with has to be really esoteric and really complicated, right? Not true. Not true. If a person listens slower, what's the strategy? We slow down. We give time. That's a gift. How many of us in this room think we really should kind of slow down our lives a little bit, right? These guys are going to give us the opportunity to do just that. Do you see how that works? Okay. By talking about improved outcomes and successful lives, I'm not trying to trivialize the challenges that parents and professionals experience right now. I think that the handicap is really lack of information that's for core curriculum for any discipline and for parenting programs themselves. I could tell you a story about each of these people. And there are way more. And it's really exciting because 10 years ago it was hard to find these stories. And now we can find them more commonly. So if I kind of establish this idea that if we have changes in the design of the brain, it's a physical disability, and we're going to see those in behaviors, is that true? If you want to argue with me, I'm perfectly happy to stay late. I only have another 5 minutes or so. But if you really disagree, if you want to kind of take it up with me, please do. Okay. I'm not going to spend time on this, except I already told you about current thinking about the DSM, which is really the timing of the release of those two, the article and the statement by the head of NIMH is really interesting because the next edition of the DSM-5 is supposed to be coming out this month after 14 years of revision. So anyway, in your handouts, I will have no more time than to simply sketch what does a neurobehavioral approach do? And how is it different? Since we know that maybe the behavioral techniques aren't going to be as effective because they don't recognize brain function, what I've developed is something called a functional neurobehavioral assessment. Most people know about behavioral assessments. They look at the antecedents and what happens afterwards, and that's just fine. But it leaves a lot of room. There are two things. One, it doesn't address etiology, and two, it leaves a lot of room open for values-laden interpretations. And what this is designed to do is simply organize our thinking differently so that we can develop person-specific, appropriate accommodations in different settings. The grid is fairly simple. You can look at the setting, you can look at the age of the person, and then kind of a global developmental age, just approximation. The first column basically asks about what the person is supposed to do in this setting. I've had people fill this out in classrooms or at home or in treatment settings, and so this can be filled out in different settings. I picked on schools because if I had a nickel for every time I heard a story of trauma associated with the badness of fit between a person and their school experience, I could have retired years ago. And this is not an indictment. There are wonderful teachers who are really struggling. The system isn't a good fit. So pretty much universally, children by age 5 or 6 are expected to be able to sit still and listen for what, 30, 40 minutes? Is that true? What? No? But in general, this is kind of like a universal expectation. Is that true? Okay. And the next column asks the question that never gets asked. In order to do that, what does the brain have to be able to do? It has to be able to process lickety-split very, very fast. The next column refers you back to the screening tool, the neurobehavioral screening tool that you will have filled out already, but we didn't have time today. And you look down at the category on processing page, and you'll say, oh, I gave this person a 5. They have very slow processing. What you've just done is put side by side in juxtaposition what the brain has to be able to do and what the person is able to do. And that's how you visualize this notion of fit. Is it a good fit or a poor fit? If it's a poor fit, oh, I'm sorry. And we also factor in their developmental level of functioning. If there's a poor fit, we're going to see secondary behaviors. Those are a flag. We don't stop there, though, because we say, okay, so this isn't working. Got that. What is going to work differently? Well, let's look at the person's strength. How do they learn best? They're visual learners. And so on the basis of recognizing that and understanding this, the accommodations emerge. We simply provide visual cues, use fewer words, and we also ask the very difficult question, is this an appropriate setting for a child who's really 3 years old? And that has to be asked, even though I know it's very difficult and really frustrating. So you have just gotten Neurobehavioral Theory 101 with the concept that the brain may have something to do with behavior. And if it does, then we now know that there's something we can do. And the accommodations can happen at home and at school and the community. And the way our research worked, and I believe that the reason that we had the strongest findings that we did, was because the design required participation by all people. So each child brought to the research project a team of people, whether it was at home or at school. The smallest teams had a couple of kids, and the biggest team was Fred's. He had 12 people on his team. The greater the frustration, the longer the chronicity of the frustration, the greater the number of people on the team. Okay. Anyway, so that was Fred, and, oh, here we go. Here. So anyway, so it works differently, and you've been very attentive for the post-carb time on day 2 on a sunny day in Portland, and this is probably not what you were planning on doing today. But thank you for being so attentive, and I know you have the rest of the day to look forward to. Oh. And just so you know, CRB has really been wonderful. They've just bought 100 books from Facets. This is Trying Differently Rather Than Harder, and these will be handed out to each of the different, what are they called? Teams? They're not teams. Boards, thank you. So you'll have this as a resource, and we're local. So again, if you have any questions, I'd be happy to say. I don't know if was it handed out to you?
Those aren't, no, but your field managers will be passing those out amongst the board, so you will see that.
Okay, wonderful. Thanks very much. Have fun.